A warm welcome to all who have taken great effort to join us in this beautiful Sunday evening. On 21st February 2023, Women in Nephrology India, WIN India, has witnessed a major milestone in its journey, inauguration of WIN Kerala State Chapter. The formal inaugural ceremony was indeed the beginning of an incredible journey of WIN Kerala State Chapter. This is a platform for providing mentorship, academics, networking, collaboration, and to provide a support system to the women nephrologists and to the entire nephrology community. We all know World Kidney Day is just round the corner, and today, WIN Kerala chapter is organizing this virtual program as part of World Kidney Day celebration, joining hands with WIN India Center team. After the great kickoff on the formal inaugural ceremony, today, WIN Kerala is adding another feather to its cap with this academic webinar. I'm extremely delighted to be the host of this program. I'll be hosting today's sessions. Myself, Dr. Jyoti Priya. I'm working as a consultant nephrologist in Muthoot Medical Center, Pathanamthitta. So let's have a quick overview of today's program, which has multiple sessions. We'll start the program with the WIN Kerala Vice President's address, and followed by we'll proceed to the academic session, starting with an interesting case presentation, which is definitely going to be a brainstorming one, which will be followed up by the much awaited talk of the evening, the management of lupus nephritis. And subsequently, we'll be having a talk on care of dialysis patients during a natural disaster, which indeed is highlighting this year's World Kidney Day theme. So in the next few hours, we'll be taking you all to a very enlightening, informative, and interactive academic platform. Without further ado, let's proceed with the various sessions of today's program. First, we'll move on to the introduction of theme of World Kidney Day and the address by WIN Kerala Chapter Vice President. For this, I invite Dr. Srilatha M, who is the Vice President of WIN Kerala and the Professor and Head of Nephrology, Government Medical College, Calicut. Over to you, Srilatha ma'am.
Okay. Yeah, my slides are visible.
Yes, ma'am.
Okay. So good evening, everybody. First of all, I welcome all of you to our national, the World Kidney Day program, national theme. Our chapter is also contributing to the CME program. I invite all of you to this great venture. First of all, I will introduce the office bearers of our WIN Kerala chapter. Our beloved president, Dr. Professor A.B. Mella Madam, who is the former professor and HOD of Government Medical Colleges Trivandrum and Kottayam, now is a consultant nephrologist at Cosmopolitan Hospital Trivandrum. Myself as the vice president, Dr. Manju Thambi, our vibrant secretary, who is the senior consultant nephrologist at NIMS Medicity Trivandrum. Our treasurer, Dr. Geeta M. Nair, consultant nephrologist at PRS Hospital Trivandrum. And we have divided our state into 3 zones, and executive committee member from each zone has been selected. And the executive committee member from the South Zone is Dr. Sripa PG, senior consultant nephrologist at Nayers Hospital, Kollam. From Central Zone, we have Dr. Reena Thomas from Pushpagiri Hospital, Tiruvalla. And from the North Zone, Dr. Jaimina P, senior consultant nephrologist at Baby Memorial Hospital, Kozhikode. So this is our faculties in the office bearers of WIN Kerala team. Now going on to the World Kidney Day theme of 2023, which is Kidney Health for All, preparing for the unexpected, supporting the vulnerable. As we all know, World Kidney Day is a celebration initiated in 2006 by the Joint Committee of International Society of Nephrology and International Federation of Kidney Foundation. And it is an annual global awareness campaign observed on the second Thursday of March every year. And this year it is coming on March 9th. World Kidney Day is to highlight kidney problems related to the common health disorders, its increasing prevalence and incidence, to encourage at least high-risk people for early detection and prevention of the disease through systematic screening, to instruct our own colleagues about all aspects of kidneys, to deal with high-risk problems and implement all the recent strategies to prevent progression of the disease, and to encourage people for kidney donation and go ahead with transplantation. So we have themes every year, different themes every year, right from 2006. And the first ever theme was, are your kidneys okay? And from then, regarding CKD, AKI, blood pressure, diabetes, kidneys for life, aging kidneys, and so on and so forth. And in 2017, it was obesity, women health in 2018, and since 2019, kidney health for everyone, everywhere. And in 22, it was a bridge the gap for better kidney care by health literacy. And 23, as we said, it is the preparing for unexpected, supporting the vulnerable. So this is the 18th World Kidney Day that we are celebrating or observing this year, 2023. We all know the increasing burden of kidney disease, averaging now about 850 million people worldwide is suffering from some form of kidney disease. And it contributes to 3% of all deaths in our population. It is the 6th fastest growing cause of death. And now it is the 12th leading cause of death. But by 2040, it is projected to be the 5th leading cause of death. So we are going to face a catastrophe of kidney disease in the future and affecting around 12.5% of population worldwide. Not only the increasing incidence and prevalence, see the survival of patients who is suffering from kidney disease. It is much below when compared to most of the dreadful cancers in the population. So it is not only increasing prevalence, but it is taking away the life of most of our patients with an early death. And overall global prevalence is roughly around 13.4%. So because of these factors, we want to educate our people and ourselves about the importance of kidney disease. And what is it preparing for unexpected? What is our experience for this? We had flood in 2018. Patient could not travel for few days or weeks for their dialysis schedule, for their regular follow-up. They are with more of infections, contagious infection. They lost their job. They have no food, more of infection because of cross were taken. Another unexpected situation was the COVID pandemic. Again, our own patients who are at high risk of developing COVID pneumonia, dying with pneumonia, lockdown, they can't travel to their dialysis centers, they skip their dialysis, acute death due to pulmonary edema, they have no money because of severe financial crisis, no drug, no food, no dialysis, and more of that. This was the recent unexpected situation that we had to face during the last few years. Now, what did we do for support our own vulnerable population? Now, Dr. Manchula will discuss about what we have, how we tackled our own problem during flood and during COVID pandemic, and how we supported our own patients for with kidney disease during these significant situations. So with this, we are going to have a discussion on World Kidney Day 2023, various aspects of kidney diseases and various other CME program. And with these few words, I introduce the topic to further discussion, and thank you very much.
Thank you, ma'am. Our president of WIN Kerala chapter, Dr. Vimala ma'am, has joined us. I request Dr. Vimala ma'am, who is the professor former professor and head of Government Medical College of Trivandrum and Kottayam, and currently working as senior consultant nephrologist in Cosmopolitan Hospital, Trivandrum. I request ma'am to deliver the presidential address. Over to you, Vimala ma'am.
Distinguished dignitaries, respected seniors, my beloved colleagues. At the outset, it was not my fault, maybe the fault of the connections that I could not join on time. I was very much before the laptop from 5 p.m. onwards. Now, let me go to the privileged presidential address. It is my proud privilege to be here as the first president of Win India Kerala chapter to deliver the presidential address. This was possible only due to the affection, love, and trust posed by my dear colleagues on me. It is not easy for any association to take off initially. This will have many teething problems. The first problem we are going to face is the registration of the association. I am sure our dynamic secretary, Dr. Manju, ably assisted by the members of the executive committee and our vice president, Dr. Srilata, we will be able to achieve this task in a very short time. The theme of World Kidney Day has been dealt in detail by my colleague, Dr. Srilata. Now, the focus of management is shifted from treatment-based disease to preventive nephrology and palliative nephrology. When we were students, or when I started my career in nephrology, every 10th patient used to be a diabetic nephropathy patient. Others we used to label as chronic CGN. Now the situation is different. When we take rounds, people even don't bother to tell us they are diabetics. They take it for granted. We know that it is diabetic nephropathy. Tell me something else. Okay, that situation should change. We should be able to educate our people the need for controlling diabetes in the first few years. They try various gimmicks, they try lifestyle, they try diet, so many things they do. They develop all complications and they come to us. By then, preventive nephrology is possible. You have only a therapeutic nephrology at that point of time. Similarly, the focus is now on palliative nephrology as well. Kashi sir and others is planning to write a chapter on palliative nephrology next edition. We all know that when a 94 or an 84-year-old man comes to you with malignancy, multiple secondaries, and he develops AKI, we know that the supporting the kidney is not going to help him at all. It is going to prolong his misery. We should be able to convince them that at this point of time, some love, affection, and palliation is what is required for the patient, and not the aggressive ventilation, dialysis, etc. That sort of approach also, I think we should educate ourselves, and we should be able to convince our patient and the bystanders on that. Very often the patients are not willing, the bystanders, somehow they want to do something or other, and they force us to do all this, when we know that nothing is going to help this patient out. Okay, so that is what we should do now. As Srilata has said, we have faced the unexpected, we have supported the vulnerable, and probably at least 50% we were successful in doing all this. So with these few words, I think the Win Kerala chapter is taking on very well, and now we are having a good team, and we will have very good academic discussions. We will also focus on social activities in various zones. We have formed various zones, as Dr. Srilata has already said, and we will be able to execute that task very efficiently. That is what I believe, and I pray, and I thank you for the opportunity. Thank you very much.
Thank you, ma'am, for that thought-provoking address. Now we'll move on to the academic sessions of today's evening. We'll start with an interesting case of acute kidney injury by Dr. Deepa KP, who is the senior resident in nephrology, Government Medical College, Alleppey. For chairing this session, may I invite Dr. Ragi Krishnan, Assistant Professor of Nephrology, Government Medical College, Kottayam. Joining her will be Dr. Devi Shruti, Assistant Professor of Nephrology, Government Medical College, Alleppey. Over to the chairpersons. I request Dr. Ragi Krishnan to introduce the speaker, Dr. Deepa. Also, following this presentation, we'll open up the webinar for question and answer session. So if you have any queries regarding our presentation and any queries to the speaker, Please type them in the question answer box, Q&A box on your screen. Over to the chairpersons.
Thank you, Dr. Jyoti Priya. Am I audible?
Yeah, you are audible.
Yeah. I think thank you, Vimla Madam and Srilata Madam, for addressing this session. And we are really delightful to join this session today. I think we'll straight away start with the academic session. Today, the first session will be by Dr. Deepa. She is a senior resident at Government Medical College, Alleppey. It's said that it is an interesting case. We'll see how much interesting it is. I think we'll straight away go to Dr. Deepa.
Are the slides visible, madam?
Yeah, slides are visible. Yes, Deepa, you can carry on.
Good evening, respected chairpersons, dignitaries, senior members of the association, and my dear friends. I'm here to present an interesting case of AKI. So presenting Mrs. V, 45-year-old lady coming from Mavelikara who has studied till 12th standard and is an Anganwadi teacher. She presented with headache for 2 days, 1 month back, reddish discoloration of urine persisting for 1 month, rash in the leg for 2 days. The patient was apparently normal 1 month back when she had headache for 2 days. During that time, she was detected to have hypertension controlled with 1 drug. 3 days later, she noticed reddish discoloration of urine, which persisted for 1 month when she was referred to our institution. At presentation, she had anemia with hemoglobin of 7, non-oliguric renal failure with creatinine of 3, macroscopic hematuria, and hypertension. She also noticed purpuric rash in the lower leg, in the left leg, which subsided in 2 days. So she had acute glomerulonephritis, rapidly progressing glomerulonephritis with lupus nephritis, infection-related glomerulonephritis, IgA nephropathy, ANCA-associated vasculitis in mind. We managed her initially with IV methylprednisolone 1 gram for 3 days, followed by oral steroids 1 mg per kg per day. We also gave her 2 units of Pagdrexel, following which she underwent a renal biopsy. The procedure was uneventful. Within next 2 days, she developed cough, dyspnea, edema, and worsening of renal failure and anemia was noted. She did not have any constitutional symptoms, pain abdomen, skin infections, no history of indigenous medicine intake. She did not have any oliguria. She was diagnosed to have diabetes 2 months back, but was not on any medications. Her personal, family, menstrual, and obstetric history were normal. On examination, pedal edema. Rest of the general examination was normal. In system examination, in respiratory system, she had inspiratory rhonchi in bilateral lung fields. Her fundus had no retinopathy, and till this period, she remained non-oliguric. Moving to the labs, in routine urine examination, she had hematuria and nephrotic range proteinuria. And blood investigation showed anemia at the outset, which required blood transfusion. She had creatinine of 3.1. Following IV methylprednisolone, there was a decrease in serum creatinine up to 1.8, which within 2 days raised to 2.7. Workup for vasculitis, lupus nephritis, anti-GBM were negative. Complement levels were normal. Stool local blood was positive on 3 consecutive occasions. And as the kidneys were sonologically normal, we proceeded with renal biopsy. In renal biopsy, light microscopy, HND stain showed 60% of presence, 2 cellular and 2 fibrocellular out of the 7 glomeruli. Segmental karyorrhexis were also seen. In silver stain, this shows a glomerulus having crescentic transformation, and Mason's trichrome stain showed fibrocellular crescent along with tubular atrophy of 20%. Immunofluorescence showed strong positivity for linear IgG in the capillary walls, and mesangial IgA and C3 were strongly positive for in the biopsy. They also had interrupted C3 positivity in the capillary walls. So by renal biopsy, she had crescentic glomerulonephritis with mesangial IgA and linear capillary wall IgG, favoring combined anti-GBM disease with an IgA nephropathy or vasculitis nephritis. With the background of cough and worsening of anemia, she underwent HRCT test which suggested pulmonary alveolar hemorrhage. So she had rapidly progressive glomerulonephritis, crescentic glomerulonephritis with mesangial IgA and linear capillary wall IgG by biopsy, purpuric rash, pulmonary alveolar hemorrhage, anemia, systemic hypertension, and diabetes. Moving forward, she satisfied the Euler-Printo criteria for IgA vasculitis, having the mandatory feature of purpura predominantly in the lower limb without thrombocytopenia or coagulopathy, and renal involvement in the form of hematuria and proteinuria. And following the algorithm for the diagnostic classification of immunoglobulin and complement-mediated glomerulonephritis, she had linear GBM immunoglobulin staining, so she was satisfying anti-GBM. Along with lung hemorrhage, she could be categorized as Goodpasture syndrome. She also had granular immunofluorescence staining for immunoglobulin and C3, and as it was IgA predominant and having features of vasculitis, she was diagnosed IgA vasculitis also. So she had both Goodpasture syndrome and IgA vasculitis. Serology for anti-GBM done twice was negative. So refining our diagnosis, rapidly progressive glomerulonephritis, crescentic GN with pulmonary alveolar hemorrhage, combined Goodpasture syndrome and IgA vasculitis nephritis, anemia, systemic hypertension, and diabetes mellitus. So at this point, we didn't know what was in front of us, and things didn't seem as simple as it was. So, doing the literature review, we had a recent systematic review of 38 articles on efficacy and safety of plasma exchange as an adjunct therapy for rapidly progressive IgA nephropathy and HSP nephritis, which mentioned flex sessions ranging from 3 to 18 sessions along with steroids and immunosuppression treatment with cyclophosphamide, which achieved remissions of 76% in HSP patients. And we followed the guidelines on use of therapeutic apheresis by American Society for Apheresis suggested by KDIGO, which suggests in IgA vasculitis associated with crescentic RPGN and severe extrarenal manifestation, therapeutic apheresis is beneficial, and of course anti-GBM disease with diffuse alveolar hemorrhage flex is beneficial. So we initiated the patient on plasma apheresis. 5 consecutive sessions were given, following which the patient improved, and 5 more alternate day sessions were given. A total of 10 sessions have been given till now. Oral cyclophosphamide initially started with 75 mg, later uptitrated to 100 mg. Oral steroid 50 mg is being continued. Electron microscopy of the biopsy and screening for malignancy is awaited. So with the initiation of treatment, her creatinine levels have stabilized and decreased, and she has clinically improved, and her radiological improvement is also seen. So our plan is to continue the oral cyclophosphamide for 3 months, oral steroids for 6 months, tapering it to 20 mg by 6 weeks, long-term immunosuppression with azathioprine. Close monitoring for relapse and complications will be done. So on further searching the literature, we did get case reports on concurrent anti-GBM and IgA nephropathy, and 16 cases as of now have been reported. Now, some of the points that are to ponder are: why anti-GBM antibodies are negative? As we know, 90% of cases anti-GBM antibodies are positive, thus 10% can have negative. This can be explained in many ways. The classical assays that we use generally detect antibodies against common epitopes. So if our patient had epitopes that are not common or to molecules like N-tactin, this may not be assayed in the panel. And moreover, the serum immunoglobulin levels have a half-life lower than the bound immunoglobulins. So if after the cessation of immunoglobulin production, if the test was done, it may not be taken up by the assay. In Y crescent show two morphology. It is possible that IgA vasculitis may be causing the crescents. So it can be of two morphologies. Can this be linear IgG due to other diseases? It is unlikely because it is in our patient, the linear IgG was very strongly positive and it had association with the interrupted C3 deposition in the capillary wall, which is more likely to be anti-GBM, and this rules out diabetes, which is the primary disease. We think that it is anti-GBM on top of IgA nephropathy, because IgA nephropathy, IgA vasculitis immune complexes can damage the glomerular basement membrane, revealing the epitopes against which antibodies may have formed and causing the anti-GBM disease. There is reverse hypothesis also mentioned in literature, where anti-GBM causes increased permeability of the glomerular basement membrane, letting the infiltration of IgA into the mesangium. And there is also a mention of KM55 antigen, which, if negative, it rules out secondary IgA nephropathy. Before winding up, I would just like to brush up through some of the definitions. Pulmonary renal syndrome is then when renal and respiratory failure is present in the patient. Woodpasture syndrome when RPGN is associated with alveolar hemorrhage. Anti-GBM disease when disease is associated with antibodies specific for components of GBM. Woodpasture disease when antibodies are specific for alpha-3-NC1, may include RPGN or lung hemorrhage or both. And Alport syndrome, Woodpasture syndrome with post-transplant and Alport syndrome post-transplant anti-GBM disease. Thank you.
Good evening, teachers, seniors, and dear friends. Thank you, Win Kerala, for giving me an opportunity to chair this session. Thank you, Deep, for such a nice presentation. So, in a patient with IgA nephropathy or IgA vasculitis with nephritis, if we come across AKI with RPGN, either de novo or during the course of illness, we should always consider the possibility of a concomitant or superimposed anti-GBM disease, even though it is a rare entity in addition to the more common crescentic transformation, and we should proceed with renal biopsy. Being a confusing case, we would like to know the opinion of the House. The session is open for discussion. Over to Dr. Agi.
Raji, are you online?
Yes, ma'am.
Hmm.
I think there was some connection problem in between.
Okay, everybody has today.
Connection problems. But this is one case which categorically, shows the importance of renal biopsy in a patient with acute kidney injury, especially.
That is true, but I have few doubts going through a presentation. No, she presented with acute nephrotic syndrome and nephrotic proteinuria, isn't it? What was the blood pressure?
He had hypertension. What was the exact blood pressure?
So now we are tempted to think more in terms of IgA as a primary presentation, and the behavior of the disease. She did very well with plasma exchange and medial prednisone. She reverted, which we don't expect so soon with a primary anti-GBM. And the conventional teaching is nephrotic proteinuria and hypertension, a little unusual, So I am tempted to think more of IgA as a prominent disease with a superimposed IgG deposition. I would like to get the opinion of others also.
We also agree with
Blood
that.
pressure on admission was 200/100, which later was controlled with drugs. And on examination, it was 140/80 on examination, time of examination.
Gomati?
We also agree with you, madam. Probably IgE nephropathy with superimposed anti-GBM disease, and we had some problem in, decision making. There was some problem, but subsequently we could start plasmapheresis on time, and in fact, the creatinine is still lingering at around 2.1, 2.2, probably because she has chronicity also. 20% tubulointerstitial fibrosis, and she has fibrocellular crescents. So she's unlikely to revert to normal, but then she can maintain a stable, renal function.
What was the urine output? Initially?
Urine output is preserved. Urine output is preserved throughout. And in fact, after initiation of plasmapheresis, urine output improved. It was 1.4 initially, and now it is 2.5 liters with improvement in serum creatinine.
Little unusual with the primary anti-GBM.
Gomati, the only 0.4 anti-GBM disease is the linear strong IgG deposit.
Yeah.
Nothing more than that, isn't it?
But
Only
this
point.
alveolar hemorrhage also, we thought it is possibly due to
Alveolar
anti-GBM.
hemorrhage.
It can occur with vasculitis, but then in presence of a strong linear anti-GBM,
Very
with
strong linear IgG is the point in favor. Otherwise, everything fits in with the IgA with crescents.
vasculitis.
I would like to add a few comments also. We had earlier 3 or 4 cases, I don't know if the Shrita remembers, in Kottayam, a double positive vasculitis, anti-GBM superimposed and ANCA vasculitis. And this it behaves more like ANCA and not like anti-GBM.
That is much more common than IgA with anti-GBM.
But the clinical spectrum is more towards IgA than anti-GBM. That's what I think. Let us see.
Dr. Joanne Bagman is here because I can see her. Joanne, would you like to, hi, this is Manju. Would you like to offer some comments?
No, I think it was managed perfectly, and probably the exact same way I would have managed it too. It's maybe too many counting angels on a head of a pin to try to figure out what her actual disease is. But the good thing is that you would treat all variations of this disease more or less in the same way. And I would have done exactly what you did.
Thank you. Thank you, Joanne.
I think if there are no more queries or questions, we'll move on to the next session. Thank you, Deepa, for that interesting case presentation. And thank you, chairpersons and all others who have led the discussion. Thank you for your valuable insights. Moving on to the next session. Lupus nephritis is always a fascinating and a perplexing area in the field of glomerular disease, and its management is quite challenging. Now, it's time for that much awaited talk of the evening, Management of Lupus Nephritis, by our eminent speaker, Dr. Joanne Bagman, who is a professor of medicine and nephrology, University of Toronto. For chairing this session, I invite Dr. Sripa PG, Senior Consultant Nephrologist, Nayas Hospital, Kollam. Joining her will be Dr. Manju Kamal, Senior Consultant Nephrologist, Apollo Athletics Hospital, Angamali. Once again, I request the participants, if following this presentation, the session will be open up for discussion. So if you have any queries, please type them in the Q&A box on your screen. So I request the chairpersons to take over the session and to introduce our renowned speaker. Over to the chairpersons.
A very good evening to all, respected teachers, senior colleagues, and dear friends. At the outset, first let me thank Win India Kerala chapter on behalf of myself and Dr. Manju Kamal for giving us this wonderful opportunity to chair this important session. We know that SLE is the autoimmune disease that we as nephrologists most commonly come across, and lupus nephritis affects about 40% of patients who suffer from SLE. And SLE, with its varying cause, remissions, exacerbations, and flares, is associated with a high mortality rate. And we have known much a lot about the pathogenesis of the disease when compared to the past, and the mortality with lupus nephritis has come down from about 50%, from about 90% in the 1950s to about 50% now. And to know more about the management of lupus nephritis, we are indeed fortunate to have an eminent speaker, Professor Joanne Bagman from the University of Toronto with us. She is the medical lead for home peritoneal dialysis program and co-director of the University Health Renal Network, Renal Rheumatology and Lupus Clinic. She is an excellent teacher and has received awards of excellence for teaching from Canadian Society of Nephrology. She is the associate editor of Journal of American Society of Nephrology and is also on the editorial board of CJASN and Peritoneal Dialysis International. I welcome Professor Bagman to share her experience on lupus nephritis with us. Over to you, madam.
Thank you very much for that nice introduction, and thank you for inviting me to speak at this session. I'm really impressed that people will get together on a Sunday evening for a session. I don't think this would ever happen in Toronto, and it just speaks, I think, to your dedication and interest in learning. So again, it's a great honor to be asked to speak to this audience. I'm calling this a personal view, and I'll just try to give you a little background on how I came onto the lupus field. So I live in Toronto, as you said, and Toronto's a very interesting city. It's very multicultural. We have a very large immigrant population, especially populations that are prone to get lupus. So we have a lot of people from Africa and African Caribbean, from the Southeast and East Asia. And we really see a lot of lupus. And, you know, lupus patients can see nephrologists, they can see rheumatologists, they can see general internists. And we decided, along with Dr. Paul Fortin, who's a rheumatologist who specializes in lupus, to establish an adult renal rheumatology lupus clinic. This was about 20 years ago. Interestingly, Dr. Fortin then moved out of Toronto to Quebec City, which is a lot more homogeneously Caucasian population. And he sees like just a fraction of the lupus in Quebec City that he saw in Toronto. And now I run this clinic for the last decade with a rheumatologist, Dr. Jorge Sanchez Guerrero. And in this combined renal rheumatology clinic, we follow about 600 lupus patients. And there are always new consultations for brand new lupus patients. This is just to show you some scenes from Toronto. There used to be a Chinatown. Many cities have a Chinatown. In fact, Toronto has 4 different Chinatowns. This is just a picture of one of them. We also have an India town, and this is the bottom picture is a picture of one of the South Asian festivals taking place in India town. So let me just give a disclaimer about myself. I am not immunologically trained at all. I am not a trialist, and in fact, I find trials a little bit boring. But just over the years, when you see many patients over and over again with this disease, you may just basically become an expert purely by exposure. And over this time, I noticed a pattern of errors that were being repeated by those who managed just the occasional lupus patient. And then when I was asked to write this narrative review, it's a paper I'd wanted to write for a long time called 10 Common Mistakes in the Management of Lupus Nephritis. So it was published in AJKD, and in fact, it was one of the most downloaded papers from the AJKD that year. So it clearly filled a niche for people who needed perhaps more guidance in treating lupus and lupus nephritis. So I'm just going to focus on some of the mistakes, and I'll start with cyclophosphamide. This is perhaps less germane than it was about a decade ago, but there's still this idea that cyclophosphamide is the gold standard of treatment of lupus and lupus nephritis. And I think that comes from a few things. One is that there was a series of trials from the National Institutes of Health, the NIH, in the United States. And what's interesting is that I actually went over all these trials from the NIH as part of an evidence review paper and realized that it was the same patients being reported over and over again. Superficially, you'd think that they had this massive experience with lupus and lupus nephritis at the NIH, but more closely, they were just reporting on the same cohort of patients at 12 months, at 18 months, at 36 months, and so on. So that was kind of interesting. The other thing is that the NIH really popularized the use of high-dose cyclophosphamide for lupus. And I think the reason it was accepted so unassumingly is because cyclophosphamide is such a potentially toxic drug that people thought it must be good if it's so potentially toxic. I'd like to go back to an old paper that was published like 40 years ago in the New England Journal of Medicine, but I just think that this teaches us a lot even now. This was a randomized controlled trial of proliferative lupus nephritis. Patients were randomized to either prednisone alone or prednisone with daily oral cyclophosphamide. This is before that high-dose IV cyclophosphamide regimen came into being around the 1980s. So this was prednisone alone versus prednisone with another immunosuppressive agent. And what this result found was that both groups had the same degree of improvement over the first few months. I think that's important. However, the prednisone-only group had more renal relapses. But the takeaway message is that the addition of the second agent did not improve the initial response rate, which seems to me to suggest that the initial response rate is driven by the prednisone. And if there is a value to the second agent, which I think there is, it is really more for long-term disease control. And something else that this paper showed, which we as nephrologists recognize, is that patients who had a lot of advanced disease at initial biopsy ended up on dialysis with either therapy. So it's an old study, but I think it's got a lot of important lessons. And what it teaches us is that it's the corticosteroid that works the fastest. And, you know, if there's studies of corticosteroid and some other agent, and the result is at 24 weeks, it may be that the result at 24 weeks is being driven exclusively by the corticosteroid. And that's why it's important to have longer duration studies. It's more expensive to do longer duration studies, but it's important to know what is actually doing what. The other thing is the corollary of this is that don't be lulled into leaving them just on corticosteroids if they're getting better, because we do know that this corticosteroid alone regimen is associated with more relapses, and more relapses, especially renal relapses, is definitely associated with worse renal outcome. So the point is you should use a second agent in addition to the corticosteroids for severe lupus proliferative nephritis, but you don't have to do this right away. This is another sense I get, that it's like day 3, the person's on pulse steroid and people are panicking because they're not yet on a second agent. The point is that the corticosteroids are doing all the important work at the beginning, and you have the luxury of waiting until you decide what you want to do about the second agent for your patient. And of course, as I mentioned, patients with a lot of established renal damage don't do well no matter what. This is the high-dose cyclophosphamide paper that I alluded to before that really, and I think not in a good way, changed the approach to the management of lupus nephritis. This is, to me, one of the most misunderstood papers published in the New England Journal. This was an outcome of 5 different National Institutes of Health protocols for lupus nephritis over a period of time. You can see the 5 different protocols that they used. Protocol number 5 was IV high-dose cyclophosphamide. That was the most recent of the 5 protocols. First of all, what's misunderstood is that people think this was a randomized trial head-to-head of these different 5 protocols, and that's not true. These were just 5 different, it was like a summary report, if you like, of 5 different protocols that were used at the NIH for lupus nephritis. And this was their result of this. On the y-axis is renal survival, or in other words, probability of no kidney failure. And on the x-axis is the different kidney survival with those 5 different regimens. So what I want to point out to you is a couple of things. First of all, group 1 and group 1A are the prednisone alone group, and they had the worst renal survival. If you just looked at this graph, this figure, which many people did, and you looked at the best renal survival, it would be the top one, which was IV cyclophosphamide. So everybody looked at this survival graph, and again, thinking this was a randomized head-to-head trial, which it wasn't, and would say, oh, it's pretty clear that the IV cyclophosphamide has got the best renal survival. But that is not the case, and that is why this figure is wholly misunderstood. So as I said, this wasn't a contemporary head-to-head study. It was just a summary report. There was varying duration of follow-up. And in fact, there was no statistical difference in renal survival among the different groups that weren't prednisone alone, though all the ones that use prednisone plus some other agent, be it IV cyclophosphamide, Imuran, oral cyclophosphamide, or some combination of the two. And the reason probably why there was no statistically significant difference among all the other groups that weren't just prednisone alone was look at the numbers. So if you look, to their credit, this had up to 160-month follow-up, so over 10 years of follow-up, which is very important. But look at the numbers remaining at the point of the 10-year follow-up. In the IV cyclophosphamide group, we're talking about 1 patient. In the oral cyclo with or without azathioprine, 1 in one group, 7 in the others, and so on. So very, very small numbers. So, is there no statistically significant difference among all these other groups just because the numbers are so small, or because there's actually no biologic difference? Again, it's pretty unclear, but people just looked at this figure, saw that the IV cyclophosphamide group was the best survival, and said, okay, the NIH protocol for IV cyclophosphamide in lupus is the best one with the best renal survival. And I think that was really a mistake. Another paper I want to talk about, which is also, I think, misunderstood, is this one. And this is the so-called Euro-Lupus protocol for proliferative lupus nephritis. Now, with the NIH protocol, with this almost like chemotherapy level dose of cyclophosphamide, there were a lot of infectious complications. So what the Europeans did instead was to use a lower dose of cyclophosphamide. Certainly, the Euro-Lupus is a lot easier to remember because it's 500 milligrams of IV cyclophosphamide, as opposed to maybe twice as much with the NIH protocol. 500 milligrams every 2 weeks times 6 doses. And that was then followed by azathioprine. Now, so this was regarded as a high dose versus low dose cyclophosphamide study. But really what troubles me is that the low dose part of this only went on for 12 weeks, every 2 weeks times 6 doses. After that, and this is a study with 5-year follow-up, the low dose group was carried on azathioprine. So why isn't this really a study of high dose cyclophosphamide versus azathioprine? Azathioprine to me didn't get the credit that it deserved for this study. Nonetheless, everyone regarded this as a high dose versus low dose cyclophosphamide study and said that there were twice as many infections in the high dose cyclophosphamide group compared to so-called low dose cyclophosphamide group, and therefore low dose cyclophosphamide group was a better protocol. And that, of course, I agree with, except, like I said, the azathioprine really didn't get the credit that it deserved because it carried the low-dose cyclophosphamide group after the 12-week mark until the end of 60 weeks follow-up. So if you and I worked on a project and I did the first 12 weeks of the project, and then you did the next 4 years and 9 months, you being azathioprine and me being low-dose cyclophosphamide, should I get all the credit? So I think not, and that's why I think this is really a high-dose cyclophosphamide versus an azathioprine study, and that azathioprine really didn't get the credit that it deserved for this EuroLupus study. As I said, after the publication in the New England Journal of that Austin paper comparing the 5 different protocols, everybody assumed that intravenous cyclophosphamide is absolutely necessary for the management of lupus nephritis. And it was really only motivated by pharmaceutical money that wanted to explore mycophenolate mofetil that we started to get a little break in this glass ceiling, if you like, that you have to use cyclophosphamide for the management of lupus nephritis. So this was a study that compared MMF to cyclophosphamide. But again, the problem with this was that the duration was only 24 weeks. And as I mentioned before, both the cyclophosphamide and the MMF group got corticosteroid. So I'm just not sure whether the difference at 24 weeks couldn't be the result of everything that was being done by the corticosteroids. I think this is too short of a follow-up to know what's doing what for the lupus and the lupus nephritis. And this was one of the results from the MMF versus cyclophosphamide group. And you can see that statistically, there was no difference between the two, no difference, MMF or intravenous cyclophosphamide, time to first renal flare, no difference between the two. If anything, there seemed to be a higher rate of kidney failure with the IV cyclophosphamide group, although again, not statistically significant. And there was double the rate of death with the intravenous high-dose cyclophosphamide compared to the MMF. So again, within the problem of this being only a 24-week follow-up, there weren't any significant signals, but certainly one could say that maybe MMF was doing just as good a job as the high-dose intravenous cyclophosphamide with fewer deaths. And in fact, a few other MMF studies compared to cyclophosphamide around that time also seemed to show a signal for fewer deaths with MMF compared to intravenous cyclophosphamide. And this really pleased me because, as I said, it was just held as religious conviction that you had to use intravenous cyclophosphamide in the management of proliferative lupus nephritis. So Sprigo went on and did an international study comparing MMF and cyclophosphamide, and as I said, on a more international level. And again, there was really not much of a difference in this international study between MMF and intravenous cyclophosphamide, except when you broke it down by race. And when it broke it down by race, people of mainly African Caribbean ancestry didn't seem to do as well with intravenous cyclophosphamide compared to MMF. And that had been shown before in the southern United States, where it seemed that people of African American ethnicity didn't respond to intravenous cyclophosphamide as well as they responded to MMF, or as well as Caucasian people responded to intravenous cyclophosphamide. The other really interesting thing, and I think leads to another common mistake in the management of lupus nephritis, is that in either group, whether they were getting IV cyclophosphamide or MMF, only about 9% were in complete renal remission at 24 weeks. And that is an important point, that I think it takes a lot longer to go into renal remission with lupus nephritis than people really recognize. So this was from the Espriva study, and it looked at rates of complete remission. And if you look at the first group, complete remission, again, didn't matter which second agent they got. At 24 weeks, a very small minority were in complete remission. So the good news about all these MMF trials was that it really did start to sway people away from this idea that you have to use cyclophosphamide for induction therapy of lupus nephritis. The bad news is that I think somehow azathioprine got missed in the shuffle. Everyone seems to have forgotten about it. And I call this the hydrochlorothiazide effect. And that is that if a drug is old and relatively inexpensive, it really can't be very good. And that, of course, is not the case. There was one study that did look at relapse rate and found that the relapse rate was higher if they were put on maintenance with azathioprine compared to MMF. And certainly I would rather be in the 16% relapse rate than a 32% relapse rate, but it's not 0 versus 100. And we shouldn't throw the baby out with the bathwater. Imuran is still a very good drug for lupus and lupus nephritis. But again, because it's old and it's cheap, people don't seem to have a lot of respect for it. When do I use azathioprine? And we in Toronto still use a lot of azathioprine, depending on the costing. If it's going to be cheaper to use azathioprine, if you're going to prescribe someone MMF or Myfortic and it's really expensive and they're going to take it every other day because it's just too expensive to take, then you're really not doing the patient any favor. If you can give them a cheaper drug that they'll actually take, that's more important. The other thing is that MMF is a BID drug if it's taken ideally. And I have a lot of lupus patients who keep forgetting to take the second dose every day of MMF. I don't understand why. I tell them, put it by your toothbrush. Do you brush your teeth at night? Yes, I do. So take your second MMF when you brush your teeth at night. I mean, it seems pretty straightforward, but they just can't manage doing the second dose. So, excuse me, I'm going to sneeze. Excuse me. I think taking a BID, taking a BID drug once a day is worse than taking perhaps a weaker drug, but it's designed to be taken once a day, taking that once a day. So if people are just completely forgetting their second dose, I will switch them to azathioprine. The other time I change them to azathioprine is we have some patients, I'll talk about getting pregnant, but they just keep getting pregnant no matter what and want to keep the child. So I would rather carry them on azathioprine than a more potentially embryotoxic agent. Another idea, and I alluded to this before, is that bad renal disease needs a bad drug. And even in nephrologists who are happy to use MMF, if the renal biopsy shows a lot of crescents or the patient has severe AKI, they will use cyclophosphamide instead. And I really don't understand that logic. First of all, I would not use IV pulse cyclophosphamide in patients who've got decreased GFR. And I note in your patient that you presented before my session today that you used oral cyclophosphamide. And I would do that too, because if you give pulse cyclophosphamide, you can end up 10 days later with life-threatening leukopenia. So I think it's better to use daily oral cyclophosphamide if you are going to use it. But the larger issue is just because a patient has crescents on their lupus nephritis biopsy doesn't necessarily mean that you have to use cyclophosphamide. In Canada, we have a cough mixture. It's called Buckley's mixture. And how it advertises itself is that it tastes terrible. You can see there, it says, got a cough, trade it for a gag. They pride themselves on how terribly Buckley's cough mixture tastes, but their motto is it tastes so bad, it must work well. And that's basically how I think people think about cyclophosphamide. It has so many potential serious side effects that it must work better than all the other agents. And there's really no evidence for that at all. Another recurrent mistake I find is not enough attention to the corticosteroid dosing. As I tell my residents, this isn't asthma, this isn't minimal lesion disease. For severe lupus nephritis, the current standard of care is 1 milligram per kilogram body weight for 6 weeks minimum if the patient can tolerate it. And then a slow taper over an unclear period. And I can't say 6 to 12 months because some patients are adherent, some aren't, some get better, some don't. It's really very variable. But nephrologists tend to forget about the corticosteroid regimen, and they're more focused on the second agent. I get loads of emails and telephone calls, and the patients say, what should I do? I've got this patient with lupus nephritis. They've been on MMF for X period of time, and they don't even mention what the corticosteroid regimen is that they used in this patient. So again, I think the corticosteroids are life-saving in the early weeks to months of the management of acute lupus nephritis or a flare of lupus nephritis. It is really what brings the disease under control the fastest. It puts out the fire. And like I said, it's sort of the corollary of the azathioprine story, is that if a drug is new and really expensive, it must be really good. And I don't buy into that either. So there's a couple of new kids on the block. One of them is Benlysta or belimumab. And this was really organized by nephrologists. And because of that, what I like about it is that it has a 2-year follow-up. Unlike all those Aspreva MMF trials that were 24 weeks, this was a 2-year follow-up. And importantly, urinary sediment was not an endpoint. That's important because the proteinuria and microhematuria can persist for a really long time, and it just confuses the issue. So, and in this study, unlike the voclosporin study, they allowed a decent amount of corticosteroid. And you can see that if you look at the complete renal remission over time, the group that had Benlysta added did have a higher rate of complete renal remission, which is great. But again, to me, this is not really earth-shattering. But people, my nephrology colleagues just seem to think if they can't get the patient onto belimumab, then the patient has no chance of getting better. And I just want to show it's not really a day or night scenario. So some of the fine print of this belimumab study that you may not realize is that in patients with the membranous variant of lupus, there was no difference between belimumab or not. There was still a really high number of non-responders in both groups. Patients were allowed to be induced with either the Eurolupus regimen or with the MMF regimen. And in those in Europe who were induced with the Eurolupus regimen, which again, just to remind you, is low-dose cyclophosphamide for 12 weeks and then Imuran, there was no difference in the Benlysta yes or no in that group. Once again, there was little difference in people of African Caribbean descent. And interestingly, now this was a post hoc analysis, there was no incremental benefit of belimumab in patients who presented with greater than 3 grams of proteinuria. So again, yes, this does seem to be a step forward, and maybe in the individual patient, it does help, but really, I just don't see this as like a magnificent breakthrough in the treatment of lupus nephritis. I will say that the side effect profile of Benlysta seems to be very good, with no major signals related to the Benlysta. Voclosporin, on the other hand, I think was a very troubled study. So this was, again, voclosporin, high dose versus low dose versus placebo, with a very rapid taper of prednisone. And in fact, we were asked to participate in our combined renal rheumatology lupus clinic, because as I told you, we follow hundreds of patients with lupus nephritis. But the taper of the prednisone was really fast. And both Dr. Sanchez Guerrero and I declined to be part of this study because of the very rapid taper in the proteinuria. So voclosporin is a calcineurin inhibitor, and it did lead to more reduction in proteinuria. But you know what? That's what calcineurin inhibitors do. For a number of physiologic reasons, afferent arteriolar vasoconstriction, stabilization of the podocytes, we know that calcineurin inhibitors reduce proteinuria. And so voclosporin, yes, it did reduce proteinuria. So, you know, is that a success? We know from all the studies of primary glomerulonephritis that if you give someone a calcineurin inhibitor, it will reduce urinary protein for the duration of time that they're on a calcineurin inhibitor. When you stop it, the proteinuria comes back. So are we really treating anything when we give a calcineurin inhibitor to reduce the proteinuria? Anyways, this was considered to be a successful study because of the reduction in the proteinuria while the group was on the voclosporin. I certainly was not convinced. I'm also very jittery about the very rapid reduction in prednisone. Nonetheless, voclosporin got licensed in the United States to be used for lupus nephritis, but it costs a ridiculous amount of money. I think they have basically priced themselves out of the market with this. So we got together and actually wrote a commentary about this, about the Aurora trial, which was about voclosporin, and Bliss, which was about belimumab, and will it revolutionize the treatment of lupus nephritis? And basically the bottom line is that they really haven't been miraculous drugs, and the quality associated life years, the amount of money that it would cost versus the benefit accrued is a ridiculous ratio, and doesn't at this point really justify the cost of these newer agents. Another point I want to emphasize to my nephrology colleagues is the importance of antimalarial drugs. And interestingly, if a lupus patient is being managed primarily by a nephrologist, they are half as likely to be put on an antimalarial than if they're being managed primarily by a rheumatologist. And randomized trials have shown that antimalarials are associated with a decreased frequency of lupus flares, including lupus nephritis flares, decreased damage accrual. They're safe in pregnancy and indeed may reduce the incidence of congenital heart block. And there's decreased thrombosis risk associated with the use of antimalarial drugs. And they are certainly on the radar for rheumatologists, but I think not so much for nephrologists. And in fact, this was a very important study, I think, excuse me, that was published about 20 years ago. And okay, it's a surrogate outcome. They looked at carotid intermedial thickening in long-term lupus patients as a marker of vascular disease. And we know that lupus patients, even if they've had an active lupus for a long time, are about 50 times more likely to die of a cardiovascular cause in their 50s compared to people without lupus. And so this looked at carotid intermedial thickness in long-term lupus patients. And what they found was that better vascular geometry was associated with two important points. One was using an antimalarial. So in other words, if patients were carried on antimalarial therapy, they had a higher chance of being without evidence of plaque, which is a good thing. And the other thing that was a wake-up call to me was that patients who were carried on a higher dose of prednisone were also less likely to have evidence of plaque. So all these years up till the publication of this study, I thought, I've got to get these patients on the lowest dose of prednisone possible. But I really think now that what we have to do is treat inflammation. And if we cut back prednisone because we don't like prednisone, and who likes prednisone, but the patients are left in a grumbling lupus state with more inflammation, that is probably atherogenic and causes changes in vascular geometry, very similar to our dialysis patients. So it was really upon seeing this, and I know it's a surrogate outcome and it's an association study, but it really sort of rejigged my mind that we have to treat chronic inflammation in our lupus patients and not just try to avoid prednisone at all costs. And because this really wasn't on the radar of nephrologists, we published this paper about reiterating the importance of antimalarial agents in the treatment of lupus and lupus nephritis. And interestingly, this was just cited again in the Lancet last month when another study came out showing the importance of antimalarial drugs in lupus. I alluded to this before, and it's using the urinalysis as a response index. The American College of Rheumatology, which, by the way, if you look at the panelists, are really mainly rheumatologists and internists, put a lot of store on the number of red cells and red cell casts as an index of renal response or renal flare. And I think this is ridiculous because if any of you have prepared slides to look at under the microscope, how long you spin the urine, how well you decant the supernatant, how hard you resuspend the pellet, really, I think plays more into how many red cells or red cell casts you're going to see under the microscope than anything else. So looking at the number of red cells or red cell casts to me is ridiculous. And I think this was just put forward by the American College of Rheumatology because none of them had ever prepared slides to look at under the microscope before. As I said before, microhematuria and proteinuria may take a long time to get better. There may also be residual proteinuria that never goes away. So that's not a reason necessarily to continue with high-dose immunosuppression or to escalate immunosuppression. And of course, they may still have nephritis and not have red cell casts that you can see under the microscope. So I think too much store is often put on urinalysis as a response index. This is another phone call I get too often, and it says, I have a patient with lupus nephritis who I treated with MMF and isn't getting better. Should I use rituximab? Everything always comes back to rituximab. So I want to come back to an analogy. Now, this has to do with primary membranous nephropathy. This is not lupus. This is primary membranous nephropathy. And what I want to point out is that even when there's immunologic cure or treatment of the membranous, it takes time. It takes time for the proteinuria to go away, and it may never completely go away. And this is compatible with this idea that there's still residual structural deficits in the absence of immunologic activity. So again, I am talking about primary membranous just as an analogy. And here in primary membranous, I'm using one of the antibodies, which is the anti-PLA2R receptor antibody. And what this shows is with treatment of this, I don't know if you can see, but the anti-PLA2R antibody goes down to 0. You can see that along the timeline. And yet during that time that you have successfully treated the anti-PLA2R antibody, there is still proteinuria. So there is a lag time between immunologic success and resolution of the proteinuria. And if you extend out the timeline, you can see that you may end up with complete remission or you may end up with partial remission. So that's the story in primary PLA2R associated membranous nephritis. And this is another primary where they actually measured the anti-PLA2R. And again, you can see with treatment with rituximab that the PLA2R went down to 0. But what the dashed arrow is supposed to show you is that at the time that it's 0, there is still significant proteinuria. So there's this lag time. But if you're only looking at the proteinuria, you may still be hammering the patient with immunosuppression because they're still showing proteinuria. So in lupus nephritis, we don't know what the antibody is. So that's why I've put an X through the PLA2R. But whatever the causative antibody is in lupus nephritis, with treatment, you may successfully treat it, but there may be a lag time while they're still showing proteinuria. It doesn't necessarily mean that you have to change or escalate immunotherapy. This shows a timeline of recovery from proteinuria from the Toronto lupus cohort, resolution of proteinuria. And what I want to emphasize to you, everybody, is the x-axis. It is 0 to 10 years. We are talking about resolution of proteinuria over years. And this isn't just a uniquely Toronto thing. This is from Ponticelli's group in Italy. And this also shows the timeline for resolution of proteinuria. And again, please look at the x-axis, which is in years and years. So like I said, this isn't minimal lesion disease. Resolution of proteinuria can take a really long time. So I have a motto, it's German, Erwarten und Tee drinking, and it means sit back and drink tea. Or in other words, don't feel like you have to escalate or intensify immunotherapy if everything's getting better, but the patient is still showing proteinuria. Sometimes you just have to wait for it to get better. Now, not scaling the intensity of the immunosuppression to the intensity of the renal disease. And there are a couple of versions of lupus nephritis that don't necessarily in and of themselves demand immunotherapy. And that includes mesangial lupus, membranous lupus nephritis with subnephrotic proteinuria, and of course, class 6 advanced sclerosing, where really the proteinuria is just due to damage and not to immunologically mediated disease. These are the most recent KDIGO recommendations for the treatment. This one is membranous lupus. And I just want to point out a couple of things that they still, whether it's low-level proteinuria or nephrotic syndrome, they advocate for RAS blockade to try to control the proteinuria. And unless I'm missing it, I think there's no evidence for this, especially for low-level proteinuria, to give the patient RAS blockade. As I'll talk about, I think that non-adherence is our major problem in lupus nephritis. And one of the ways to approach non-adherence is to give the fewest number of drugs possible. So I am really mindful of how many drugs I give our young patients with lupus nephritis. And I really don't see much of an indication for RAS blockade, particularly in patients with low-level proteinuria with membranous lupus nephritis. Now, the other thing is that many patients with lupus membranous will respond to corticosteroids alone, and no one really knows whether they need a second agent. This is from Europe, where they have used rituximab monotherapy for lupus membranous. It's not really a steroid-free therapy because they do get pulse corticosteroid. But they did show that patients with lupus membranous nephropathy, they were given prednisone, as I said, and rituximab itself was also given with a high dose of methylprednisolone. So one thing might be rituximab with corticosteroid for lupus membranous. I don't know about in your part of Kerala, but it is very hard in Ontario, my province, to get rituximab therapy. You have to get, the patient either has to have private insurance or get coverage from the government, and it's very hard to get. This is a study from Brazil that showed in patients with lupus membranous that prednisone alone worked just as well as prednisone with a second agent. So my own personal approach to lupus membranous, For subnephrotic proteinuria, I just observe. I, again, am not convinced that you need to put these people on RAS blockade. If they have nephrotic range proteinuria, I do put them on prednisone. I tend to use about 0.5 milligram per kilogram for about 3 months. You can add low-dose cyclosporin or tacrolimus, which I think will reduce the proteinuria, but I don't know if that's actually treating anything immunologically. And they may have to stay on low-dose cyclosporin for a long time just to control the proteinuria. But again, my sense is that it's not necessarily putting the membranous lupus into remission. Another thing that people don't consider is the main morbidity from lupus membranous is not necessarily kidney failure, but is thrombosis. These people are hypercoagulable. And I think if they're on oral contraceptives, that these should be stopped. Obviously, they shouldn't get pregnant, so they should be on an alternative form of contraception, but I don't think they should be on estrogen-containing oral contraceptives, because to my mind, that just makes the thrombosis risk too great. The other thing about the ALMS trial, which was the one I showed you about MMF versus cyclophosphamide, they decided to look at the subgroup that had membranous. And what they showed was that there was no difference in the membranous group that got cyclophosphamide and the membranous group that got MMF. So they concluded that there was no difference between the MMF and the cyclophosphamide group. But both groups got corticosteroids. So maybe it was the corticosteroids that did all the work in the membranous subgroup of the MMF group. In other words, one group got steroids and cyclophosphamide, the other group got steroids and MMF, and they said that there was no difference between the two, so cyclophosphamide worked just as well as MMF. But what if it had been high-dose steroids and cyclophosphamide versus high-dose steroids and Diet Coke? And let's say there was no difference between the two. Would people say that cyclophosphamide was the same as Diet Coke? Of course not. Maybe it was the steroids that were doing all the work. So this was published in KI, and I'm amazed that it got past peer review without mentioning the possibility that maybe the patients were just responding to the high-dose corticosteroids in this subgroup with membranous in the ALMS trial. So again, this is a personal talk, and I am in the minority about this, but I'm not sure that calcineurin inhibitors treat lupus nephritis in an immunologic way. And just like everyone glommed, no pun intended, everyone glommed onto the NIH protocol cyclophosphamide after the publication in the New England Journal, everyone glommed onto this cool idea of multi-targeted therapy of using a calcineurin inhibitor plus MMF versus cyclophosphamide for a 4-week trial. And like I said, calcineurin inhibitors, like the voclosporin study I showed you, will reduce proteinuria, but they probably do it in a non-immunologic way. And when you stop it, the proteinuria comes back. So if you need to control the proteinuria because a person has anasarca and is a wreck, okay, that's reasonable to use calcineurin inhibitors. But my sense is that the DNA antibodies don't really go down, the complements don't come up. I don't think we're really treating it immunologically when we use a calcineurin inhibitor. But if you want to design a study to show CNIs in a good light, like they did with voclosporin, just look at proteinuria as the outcome, and you will see a reduction of proteinuria, and that can be taken as a positive outcome, but I'm just not so sure. So I just want to show you that tapering schedule from that voclosporin study, and you can see that like by 2 months, 8 weeks, they're only on 5 milligrams of prednisone, and that really was considered just way too fast for us, and that's why we declined to be part of the study. And there was a signal too with the voclosporin for more bad events with the voclosporin. And by the way, beside the fact that there was reduction in proteinuria, there was no difference in GFR among all the 3 groups. So again, the only so-called positive result from the voclosporin was the reduction in proteinuria. And like I said, maybe who cares? And as I said, this is the signal for the adverse events. And there was a signal, especially with the low dose voclosporin compared to the high dose voclosporin, which doesn't make a lot of sense, but they were both higher than they were with the group that got immunosuppression without voclosporin. So everybody, I think after years and decades of treating lupus, that there's no magic bullet. As you said in the introduction, the outcomes are much better than they used to be. I think still most bad outcomes in lupus. Yes, there are some people with terrible disease, but most bad outcomes in lupus are the results of non-adherence to therapy. As of this year, I think there are no miracle treatments for lupus. And just because a new medicine is ridiculously expensive, it doesn't mean that it's a magic bullet for our patients with lupus and lupus nephritis. And Galen said that everything works in mild disease and nothing works in severe disease. And I'm afraid that I think that that applies a lot to our patients with severe lupus and lupus nephritis. Another mistake is non-adherence. And the cruel joke of lupus is that it's young females who are in their most self-conscious stage of life who get lupus, and that the principal medicine, corticosteroid, can lead to profound changes. And medication adherence is hard enough in young people without the side effects of corticosteroid. And everybody, I think I can say after decades of treating lupus, that I think non-adherence is way higher than we can even begin to imagine. So I went on a battle with KDIGO when they put out their last set of guidelines for the treatment of lupus nephritis a decade ago. And they said if the patient is not responding, they said, oh, well, if they're using one drug, use another. If they're using the other drug, use a different one. Maybe do another kidney biopsy. Consider IVIG. Consider rituximab. It's always consider rituximab. And I was gobsmacked because no one said anything about maybe they're not taking their pills. And the reason that it's resistant is because they're not taking their pills. So the major cause for resistant lupus nephritis is, I think, non-adherence to therapy. And think about this, if the serology is not improving, usually the hemoglobin is one of the first things to improve. Think of it if the patient doesn't look Cushingoid. And think of it if they can't tell you how many prednisone tablets they take every day. If they're on 40 milligrams of prednisone a day and you've prescribed them 5 milligram tablets, they need to count out 8 tablets every morning. So if you just casually ask them, how many tablets are you taking every morning? And they have to start doing the arithmetic, then they're clearly not counting out 8 tablets every morning. Anyway, I went on this campaign against KDIGO for about a decade, and I'm happy to say that now in the newest version of KDIGO, under resistant lupus nephritis, the #1 point is to verify adherence. And we can't check MMF levels. I don't know if you can, but you can, call the pharmacy and see if they filled their prescription, if they renewed their prescription, and so on. So I consider that a victory, and it really helps to really share the knowledge that non-adherence is much higher than we could even start to believe. So how do we increase adherence? I have no idea. I think many patients are not told that lupus is a life-threatening disease. If someone's told that they have cancer and they have to undergo chemotherapy, they realize that they're going to get sick, that their hair is going to fall out, all those sort of terrible things, but they know they've got cancer and they've got to do this to treat the cancer. I don't know if anyone tells that to lupus patients, that you've got a life-threatening disease and you can die from this just as much as you can die from cancer, and that you're going to have to take medicine that's going to give you a lot of side effects, but it will treat the disease and you'll get better. And I don't know that we actually have that conversation with the patients so that if they do take the medicine and they develop some acne, they don't stop taking it out of horror because they didn't realize they were going to get acne. We have to prepare the patient that they're going to get side effects from the medication, but that they've got a serious disease that they can die from. So my new quibble with KDIGO, just in case you've looked at the guidelines, is the following, and that is induction therapy for proliferative lupus nephritis, presumably class 3 or 4. And what they recommend, to my amazement, is intravenous pulse steroids, followed by either MMF or Urolupus protocol or whatever. And this is really amazing to me. And let me tell you why. Because at least in my area, this is a big deal to give intravenous methylprednisolone. You'd have to bring them into a medical day unit or an infusion unit. IV pulse steroid is not a benign therapy. It's been associated with sudden hypertension and acute pulmonary edema. And importantly, there's proliferative lupus and there's proliferative lupus. So here's a patient, sick proliferative lupus, presents with malar rash, high blood pressure, acute renal failure, class 4 lupus nephritis. Sure, this is a totally appropriate hospitalized patient to give pulse corticosteroid. I agree 100%, and that is how I would treat this patient with class 4 lupus nephritis. But here's a different patient. This is someone who's doing okay, has normal kidney function, but has some polyarthralgias, a bit of a sun-sensitive rash, and some microhematuria. Lupus serology is positive. The family doctor refers the patient to you. You see her about maybe a month later. You get her in for a kidney biopsy a couple of weeks after that. She's got, again, class 4 lupus nephritis with normal renal function, normal blood pressure, everything. Does this patient have to be whipped into hospital and to get pulse corticosteroid? That makes absolutely no sense to me. This is a totally different patient from the first patient. And just because they both have class 4 lupus nephritis doesn't necessarily mean that they both have to get pulse solumedrol. So I totally disagree with that recommendation. Context is everything. So patient 1 is sick, has rapidly progressive glomerulonephritis and needs, and I totally agree about the pulse solumedrol. What are you going to do with patient 2? They feel pretty well. They've already waited a few weeks to see you, then waited for the biopsy and the biopsy report. All of a sudden, because you have the result that it's class 4 lupus nephritis, you're going to bring her into hospital and give her IV steroids. It really seems to not fit the context. Now, I think this is the last thing I just want to talk about, but I think it's so important. And again, it has to do with adherence. And that is that better is the enemy of good. And the more medicines you prescribe, the lower the adherence. We know that. So the most important medicine at the outset is prednisone, and maybe also the second disease modifying agent, but prednisone is the most important thing. So the most easy thing you can do is to give 1 50 milligram tablet of prednisone, make it as easy as possible, and say, take this with breakfast every day. So this is a true story. This is a patient who was referred after hospitalization to our lupus clinic for follow-up. She's socially marginalized. She has a long history of lupus, totally non-adherent, repeated flares, and she's no-show to a rheumatologist for 2 years. And you know, if someone is no-show, it means they're not taking their medication. She presented now 5 years ago to the hospital. We didn't know this patient, but she presented to the hospital with a severe flare, including nephritis, and she was treated in hospital, and she was discharged with follow-up to our renal rheumatology clinic. And I want to show you all what her discharge medications were. She was discharged on prednisone, 20 milligrams BID. Okay, I would have done 50 milligrams once a day for simplicity, because we're now getting into BID, which means that she may miss some, but okay, I can live with it. She was put on my Fortic 1080 BID. Hydroxychloroquine, important drug. You don't have to start it right away. It's more of a long-term agent, but she was put on hydroxychloroquine. Oh, to lower the proteinuria, she was put on Ramipril, 2.5 milligrams daily. Like that is a total waste. She was hyperlipidemic because of her proteinuria, so she was put on atorvastatin, 40 milligrams daily. She had some evidence of hemolysis, so she was put on folic acid, iron for good measure, pantoprazole for gastric protection, Septra, which I don't even think you need, but she was put on Septra for PJP, prophylaxis. Her heart rate was fast, so she was put on metoprolol, 12.5 milligrams BID, vitamin B12 for good measure, and of course, calcium and vitamin D. She was discharged on more than 30 tablets a day. This young, non-adherent patient who, if we were lucky, if we could get her to take 50 milligram tablet of prednisone a day, I think we would have been ahead of the game. This was absolutely ridiculous. You have to be mindful of how many pills you put on these young, non-adherent patients. We talked about this before, about not reducing immunosuppression exposure in patients with advanced CKD. And I think we nephrologists are more aware of this problem than rheumatologists are. You need to monitor the side effects of immunosuppression, including ocular toxicity, bone mineral density and stuff, which is why I personally am happy to do the clinic with a rheumatologist, because they're the ones that worry about the bone mineral density. And damage accrual over time is mainly due to the corticosteroids with musculoskeletal complications. The last thing is the unnecessary high-risk kidney biopsy. And this is something else that really puzzles me. So patient presents with obvious explosive lupus, elevated creatinine, blood and protein in the urine. And why do they need a kidney biopsy at that time? You know what the diagnosis is. And if you're going to do a kidney biopsy, it's probably a high-risk kidney biopsy. So I mean, like I say to my colleagues, what do you think this is? Amyloid or IgA nephritis? It's going to be lupus nephritis. So, or if a patient is presenting with severe extrarenal lupus that's going to mandate intensive immunosuppression anyway, why do you need to do a kidney biopsy at that point anyway, when it's not going to change therapy? So one should have a patient have a renal biopsy. I think it's probably more informative around a decision to decrease immunotherapy. Let's say, you know, someone that does have proteinuria, and I said you do have to wait a long time, but if the proteinuria is worsening where everything else is getting better, maybe they need a kidney biopsy. Same if, let's say they've got diabetes and you're worried that maybe they've got diabetic nephropathy, or they've got antiphospholipid syndrome, maybe they've got thrombotic microangiopathy. Those might be reasons. But when patient presents with an obvious presentation of lupus or an obvious flare of their lupus and they've got renal involvement, I really don't think that the risk benefit of kidney biopsy justifies a kidney biopsy, except in the most unusual circumstances. And then finally, pregnancy. We had a high school student who developed lupus, had renal failure, proteinuria, was treated with high-dose steroids and MMF, and came to clinic and follow up, and she was so happy. She was ecstatic. Doctor, I have great news. I'm going to have a baby. So the patient may not know that pregnancy during a lupus flare is high risk unless you tell her. She may just see that as something totally a different aspect of her life. There's, of course, the risk of the potentially teratogenic medications. So you have to tell the patient that they can't get pregnant. So these are the mistakes and what I think we can learn, or what my personal viewpoint is. I've talked at length about how cyclophosphamide is not the gold standard treatment, and it isn't that worse lupus deserves a worse drug. And don't forget about azathioprine. Long-term high-dose corticosteroids, I think, are still important in the treatment. Antimalarial drugs are underused by nephrologists. Don't use microhematuria and CAS as response criteria in isolation. scale the intensity of the immunosuppression to the severity of the renal disease. Non-adherence is the commonest cause of treatment failure. Minimize the number of drugs that you prescribe for your patient. Think about diminishing returns if a patient's got advanced CKD when you're deciding about whether to treat another renal flare or not. You need to monitor for side effects of immunosuppression. You don't have to do a kidney biopsy in the face of an obvious diagnosis, especially if it's a high-risk kidney biopsy. And of course, don't forget to counsel about pregnancy before they get pregnant. And with that, I'll thank you for your patience and your attention, and I'm happy to take part in discussion.
Thank you, Dr. Breckman, for that lucid talk. It was really a thought-provoking one, an amazing presentation. Thank you, ma'am. Now the session is open up for discussion. I request the chairpersons to lead the discussion. Over to the chairpersons.
Hope I'm audible.
Yes, ma'am, you're audible.
At the outset, let me thank the Win Kerala's chapter to give me this wonderful opportunity to chair the session. And thank you, Professor Beckman, for such a wonderful talk on lupus nephritis. Thank you for sharing your vast experience, years of experience in treatment of lupus nephritis. And actually, it gave us an insight and to look into things in a different way, especially when you mentioned regarding the high dose versus the low dose cyclophosphamide and the role of azathioprine. Actually, I think it is a new way of looking at it altogether. So thank you for that. And lupus being a problem which perplexes all of us treating nephrologists because of its unpredictable course and all, I'm sure that there'll be a lot of active discussion about this from the other members also. And I also like to mention, I came across an article by you written in Nature long time back regarding the role of nephrologists in treating lupus nephritis. And I think with maybe 10 years or more than that, past that, and with so many other subspecializations, the diversification, still it holds good that we should be taking an active role in the treatment of lupus nephritis. So Professor Bergman, my query regarding this is, one thing I would like to know is the duration of the maintenance phase of lupus therapy. The KDIGO says it should not be less than 36 months, but can you actually give us, like, it might not be easy to give a number as such, but what would be your take on that? And what are the parameters that should help us to decide when to stop treatment? Many a time, as you have mentioned, the proteinuria may be persisting, but the immunological activity may be quiescent. So shall we go for a repeat biopsy or something? Or what should be the point that should come into our consideration when we are treating stoppage of treatment in a case of lupus nephritis?
Thank you for those are two great questions. So in terms of treatment of the initial presentation or the flare, I agree. I think at least 36 months of the second agent is warranted, especially if it was severe involvement of the kidneys. And, it doesn't mean they have to be at full dose. If you have someone on MMF, let's say 1 gram twice a day, maybe and again, things can either go well or they can go not well. Let's say everything is a best case scenario and they're taking the medicines, they're going into remission, everything's going smoothly. You could do a bit of a taper of the MMF, which I do frankly just as a psychological plus to them to see that their medications are being decreased. But yes, I would plan for at least 36 months, even in the best case scenario. Sometimes it's not the best case scenario and they stop taking their drugs and they flare again, and then you have to retreat. And then sometimes we keep them on indefinite amounts of the second agent. And of course, then the whole question is, do they want to get pregnant? Because if they want to get pregnant, then what we do is we wean them off the MMF and put them on azathioprine in plans for pregnancy. But I think the 36-month minimum is a reasonable one, but every patient is different. Now, in terms of stopping therapy, which was your second question, that is a very vexing question. And again, in the best case scenario, someone responds, they take their medicine, they're doing really well. And let's say now we're at the point, it's 36 months, they're on 500 milligrams twice a day of MMF, 5 milligrams of prednisone. What do you do? And I'll tell you what I do is I have no idea what the right answer is. So I discuss it with the patient. And I say, there are no good studies. There's some observational studies, but there's no great studies about stopping immunosuppression at the point where everything's looking really good. And so it's up to you. And believe it or not, like, it's not like everyone grabs at the chance to stop their medications. I think it's 50-50. And about half the patients are happy to stay on low dose ongoing immunosuppression because they were so sick when they presented and they're too scared to get sick again. So they would rather stay. But having not the hard evidence to recommend for myself strongly one way or the other, I do it on discussion with the patient.
Thank you, Professor, for that. And now on to Dr. Sripa
Thank
for
you,
any
ma'am, for
further.
the critical analysis of the various treatment protocols, and very happy to like us of for having reminded us of persistently using steroids for a longer time, and also underlying the use of hydroxychloroquine use also has been emphasized by you. And though we have many more new drugs in the horizon, they are like shining stars which are still yet to prove their mettle. So we have 2 questions in the chat box. Dr. Manju has asked whether whether the class of lupus nephritis will decide on the second immunosuppressant that you use. And another question from Dr. Ragi is about the treatment protocol that you use at your center for class 4 lupus.
Yeah, so class 3 versus class 4, to my mind, are the same. So, you know, if you have 7 glomeruli in the, I don't know if we have a pathologist online who wants to comment, but if there's 7 glomeruli and 3 out of 7 have endocapillary proliferation, that's less. If 4 out of 7 have endocapillary proliferation, that's 150%, that's class 4. To me, it doesn't make a difference. So I treat class 3 and class 4 the same. As I said, sorry? Okay, I'll go ahead. So, and again, the severity, as I said, context is everything. And if they're sick with rapidly rising creatinine, we'll bring them to hospital and give them pulse steroid, and then change to 1 milligram per kilogram body weight of daily oral corticosteroid. And then usually we start MMF, but like I said, there is no rush to start the MMF, and you can start with a low dose. You don't have to put them on like 3 grams from the get-go. Start with like 500 milligrams twice a day. Make sure they tolerate it, because as I said, all the putting out of the fire is going to be the corticosteroid. And like I said, if it's class 3 or 4 and it's not this acute, rapidly progressive kind of presentation, then I will just start 1 milligram per kilogram body weight of prednisone. And as I said, if I have worries about compliance, I'll just round that to a 50 milligram tablet of prednisone to start with. So that's sort of our, in broad strokes. Again, it depends on the severity of the presentation.
We have a few questions in the Q&A box. Can I proceed with that, ma'am?
Yes, please.
Dr. Pyle has asked about your opinion about dosage and duration of IV pulse methylprednisolone if you're considering it in a patient, and also on the routine use of bisphosphonates. Are you using it routinely? That's her query.
Yes. So pulse, again, if we're in that first context I showed you with rapidly progressive glomerulonephritis, we'll use, again, depending on the size of the patient, but maybe 250 milligrams of Solumedrol IV daily times 3. If it's a bigger person, maybe 500. There's very little science around the dosing of pulse Solumedrol. And I used to use 1 gram at daily ×3. And then I had someone go into acute pulmonary edema and it scared the heck out of me. So I've sort of cut back a little bit. And so that's why I use lower doses of pulse Solu-Medrol, but it's usually IV ×3 and then changing to daily oral prednisone. We don't use bisphosphonates at all. I don't know why, we just don't. Again, I try to keep it simple. And as I said, I even manage these patients with a rheumatologist who doesn't seem particularly disposed to use bisphosphonates either.
Thank you, ma'am. We have another question from Dr. Jaimina, madam. How to treat elderly lupus nephritis, class 4, presenting as RPGN, age 75 years, with risk of immunosuppression versus infection?
Yes, that's a great question. And thankfully, it doesn't happen too often that we have. But I'm just speaking now with no evidence to back this up, but I would just sort of cut back on the doses. If it was RPGN, then I would probably give something like 100 milligrams IV Solu-Medrol daily ×3, and then a milligram per kilogram if I could for a few weeks. And then again, with the second agent, go with lower doses, maybe start with, depending on the size of the person, MMF, maybe 250 BID, and gradually try to titrate up to a maximum of 1 gram BID.
Okay, thank you, ma'am. We also have one more query from Dr. Jaimina, ma'am, regarding the treatment of lupus podocytopathy.
Yes, I treat lupus podocytopathy very similar to minimal lesion disease. And indeed, I have a young woman now with lupus, her biopsy was read as lupus podocytopathy, but she behaves just like minimal lesion disease. And indeed, like she flared so quickly, she behaved more like frequently relapsing minimal lesion disease than lupus podocytopathy. But in her, we were using corticosteroids, and at the ripe old age of 22, she's developed a vascular necrosis of the hip. So we were able to get permission to use rituximab. So we're actually using rituximab in her now.
Okay, thank you, ma'am. Dr. Susan, ma'am, has raised another query. Can we stop steroids in lupus nephritis if remission is sustained? And how long to continue drugs?
Yes, I addressed that before, and I don't know the answer. We've had some patients who've been in remission for like close to a decade, and we've gone, from 5 milligrams to 4 milligrams to 3 milligrams. Some of them are on 1 milligram of prednisone, and I honestly don't know if we're just treating ourselves. I don't know that 1 milligram of prednisone is going to do anything for anyone with lupus, that it's going to stop a flare, and whether we're just doing it to make ourselves feel better. So that's why I say I have a discussion with the patient about what they want to do. And like I said, the patient 50-50. Sometimes they do want to continue on low dose immunosuppression, but there really is no good data to guide this decision.
Thank you, ma'am. Another query, if you are not depending on urine protein sediments for assessing response, is it only the creatinine on the basis of which you decide to hike up immunosuppression, say after 6 months, if they don't have any extra renal activity? That's a query from Dr.
That's a very
Raghunath.
good question. If the creatinine's going up, then that's a worry. Okay, what I'm saying is that very often these people present with, let's say, 6 grams of protein and a creatinine of 1.2, and then a few months later it's 3 grams of protein and the creatinine is still 1.2. I'm just saying at that point, you don't necessarily have to intensify immunosuppression, and it's a bit of a waiting game. And then if everything else is getting better, I would tend to sit tight and just wait. And it's only if, like you said, if the creatinine starts going up, or if the proteinuria starts going up, or there wasn't microhematuria, now there is microhematuria, or the complement levels start dropping, that might be a reason to do a renal biopsy in case the lupus is reactivating. Usually if they're taking their medication, things will go in the right direction. If everything's going in the right direction and all of a sudden at 6 months, the complements start dropping and the DNA antibodies start going up, I am strongly suspicious that the patient has stopped taking their medication.
Thank you, ma'am. Dr. Jayamina ma'am has raised another query. Transplanting a patient with lupus nephritis with persisting low C3 and high titers of anti-dsDNA, inspired 1 year on dialysis with prednisolone 5 mg per day, should immunosuppression be hiked?
That's a great question, and I don't know the answer to that. I would punt that to my transplant colleagues, because they're the ones that see the recurrent lupus. I would punt that to them. My gut feeling would be yes, probably you should, or maybe they would want to do a biopsy and see, although it'd be high risk in a dialysis patient. But I don't know. I would punt that one.
Okay, thank you, ma'am. And last question: reliance on repeat biopsy in diagnosing flare by role of newer biomarkers.
Yes, it's a whole bunch about new urinary biomarkers. We get a lot of the submissions to Jason about that. I don't find them tremendously helpful right now. And that's another point, is if someone's got lupus and they've been fine for a while, the average flare rate, I think, in lupus in adherent patients is about once every 4 years. So lupus is a disease that flares. So if you've got someone who's done well, and then 4 years later, 5 years later, they present with a flare with blood and protein in the urine, I don't see any justification for doing kidney biopsy. They're having a flare and they've got a renal flare as part of their flare, and you need to treat the flare. I don't see that they need a kidney biopsy at that presentation. It's not like they've suddenly developed amyloid or minimal lesion or something. It's a lupus flare and they've got lupus nephritis, and I wouldn't put them through a biopsy just based on that alone.
Thank you, ma'am. Actually, we have one more query. Do you do CMV testing in lupus patients?
No, we don't. And luckily we haven't had that problem. We also don't put them on PJP prophylaxis. With our years and hundreds of patients, we've never had anyone with PJP with lupus.
Thank you, ma'am. I think we had answered almost all the queries. Thank you so much, ma'am. We had a great talk and a very great discussion. Thank you. Thank you, chairpersons also.
Thank you very much for inviting me.
Thank you. So we will move on to our next session, the penultimate session. We all have witnessed how a pandemic can create a significant impact in the delivery of essential services to our patients with kidney disease. In the event of such unforeseen disasters, our dialysis patients are among the most vulnerable set of population who will be facing the brunt of such calamities. Our next session will be focusing on this crucial issue. We'll be having a talk on care of dialysis patients during a natural disaster by Dr. Manjula Ramachandran, Senior Consultant Nephrologist, Marsliva Medicity, Kottayam. For chairing this session, may I invite Dr. Srija S. Nair, Consultant Nephrologist, Cosmopolitan Hospital, Trivandrum. Joining her will be Dr. Varada Aravindan, Assistant Professor of Nephrology, Government Medical College, Thrissur. Over to the chairpersons. I request the chairpersons to introduce Dr. Manjula Ramachandran.
Good evening, everyone. Am I audible?
Yeah, you're audible, ma'am.
Okay. So first of all, I would like to thank the office bearers of the WIN Kerala for giving me this opportunity to chair this session. So as you all know, our next session will be regarding the theme of the World Kidney Day 2023, that is Kidney Health for All, preparing for the unexpected and supporting the vulnerable. So that's basically to raise the awareness about the disasters event, that is the natural disasters and their impact on people living with kidney disease, especially the dialysis patients. We have all witnessed those during the COVID times. Their access to the treatment as well as medical care were often hindered very much in such situations. They face many challenges. So we will now see what we can do about that. So to elaborate on the topic, we have a very enthusiastic academician with us, Dr. Manjula Ramachandran, who is a senior consultant nephrologist at Marsliva Hospital, Kottayam. Madam, we are eager to hear from you on the topic. Over to you, ma'am.
Am I audible? Am I audible?
Yes, ma'am, you are audible.
Okay, thank you. I think my slides are visualized.
Yes, ma'am.
Yes, ma'am.
Yes.
Okay. A very warm good evening and World Kidney Day wishes to my seniors, my dear teachers, and my friends. The very next day after Dr. Manju Thambi gave me this assignment, I ran into a sort of severe influenza-like illness and the viral laryngitis of which I haven't recovered much. Hence, I would be apologizing if in case during the talk my voice gets cranky. Please pardon with me. We had an excellent academic feast. Now we will go back to a different topic which we are not used to hear or deliver during our clinical meetings. This is a chapter from community nephrology. What lessons we can be learned from disaster nephrology? Just now we get an excellent review of lupus nephritis by Madam Bergman, who clearly taught us that if we don't treat the disease properly, this could turn into a personal disaster for the lupus patients whom we encounter in our day-to-day practice. But until a few years back, we never thought we'd be dealing with the lives of our dialysis patients during natural disasters, because we thought natural disasters are not going to happen in our lifetime. They're aberrations which occur like once or twice in a century. But unfortunately, from various parts of the globe, there are reports of natural disasters in its increasing frequency, severity, and in its impact. And we have just come out of a viral pandemic, a global epidemic which knew no boundaries. Also, in the last few decades, we have witnessed an alarmingly enormous rise in the number of dialysis patients who are entering kidney replacement therapy from all parts of the globe. So this patients, their life is sustained by a complex, coordinated, uninterrupted care called dialysis. And during a natural disaster, these are the most vulnerable, most hardly hit by the disaster. Hence, when the World Kidney Day Joint Steering Committee comes out with this theme, it's a pointer towards us that it's time for us, the renal care providers, to look into this aspect and to come to the forefront of saving the lives of our dialysis patients during a natural disaster. Anjita, moving here. Sorry, the slides are not moving. 1 second. So there's a problem with the moving. Okay. Fine. When the Hurricane Maria, with its sheer destructive force, struck the otherwise peaceful island of Puerto Rico in an early fine morning in September 2017, destroying its 70,000 homes, knocking down 80% of electric poles and cell phone towers, rendering its 3 million population homeless, of which 6,000 were dialysis patients. Almost all the dialysis facilities stopped functioning, and only a few could manage to return within the first 2 to 3 days after the disaster. Many of the dialysis patients migrated to other parts of the country. We don't have an estimate of the migration or outcomes of dialysis population of Puerto Rico, but the personal anecdotes say that most of these patients never returned to their homeland. And this data from US, which shows that in 1980s, if the average frequency of natural disasters was only 3 in a year, in 2020, it has come up to 22 in a year. And this graph clearly depicts that up to 1980s, the incidence of natural disasters was remaining a plateau. Then it started to rise and showed a peak pattern in the last decade. About 48% of all the natural disasters occurred in the last decade, and 30% of all the disasters in the Neo world has occurred in the last 5 years. And about 75% of these disasters are reported to occur from Asia Pacific region, of which China tops the list, followed by Vietnam, Philippines, Japan, and India. Of the 36 states and union territories of our country, about 27 are disaster prone. And there is a report from Center for Science and Environment which says that India had witnessed some form of natural disaster almost every day in the first 9 months in 2022. And Odisha has been termed as the disaster capital of India. What about our state, the God's own country? Keralites were rudely awakened to the reality of natural disasters when in 2017, the cyclonic Orkay struck the coastal belt of Kerala. Soon in 2018, we witnessed severe floods. Then we thought it was only an aberration which had occurred once in a century. But soon we had to accept the fact that these floods produced by torrential rainfalls during our monsoons, as well as the landslides occurring in many districts of the state, has become a routine yearly occurrence now. The state has no data of the outcome of dialysis patients during these floods. And in the observations by the State Disaster Committee, headed by Dr. Murali Tamarakudi, there is an observation that Kerala has to make far-sighted and focused policy interventions to ensure that the human development state percolates to the vulnerable populations also, and that the state miserably failed in taking care of its vulnerable populations during the floods. This moment also calls for an applause to our dear colleague, Firoz Aziz and his team, for reporting the impact of floods in dialysis delivery in Northern Kerala, published in 2020 in Kidney International. This study, which they had done by telephonic interview of the nephrologist and the staff in charge, and the data was collected from all these dialysis centers. Of the 111 dialysis centers in Northern Kerala, they found that 19% of the centers and 7% of patients were affected by the floods. Of the 21% centers, 15 were waterlogged, and in 17 centers, water was contaminated and RO was disrupted in 4 centers. Power supply failure occurred in 28 of the 110 centers, and 36% centers had excessive accessibility issues for patients and staff. So 38% of the affected patients had to miss HD sessions, but all the other patients could be accommodated in the other units. And 11 patients required hospitalization. 4 patients died during this period, and the affected units returned to the normal functional status within 2 to 14 days, except 1 unit. And in this conclusion, they have stressed upon the need for networking for contingencies, and also the state has to formulate remedial measures for the future. Natural disasters are acute, extreme events occurring due to environmental alterations. But in relation to health, its definition differs in that it's a destructive event that causes the discrepancy between the number of casualties and the treatment capacity. It's a situation in which need for medical care exceeds the immediately available resources, and in which extraordinary and coordinated measures are necessary for maintaining even the normal quality standards. Disaster nephrology is emerging as an area of expertise within the nephrology is an area of nephrology dealing with the problem of acute and chronic kidney disease patients during and subsequent to disasters. 3 types of renal failure patients who might require dialysis during disasters are: majority are the ESRD patients who are already undergoing maintenance hemodialysis, and the rest are CKD patients who are not yet started on hemodialysis. And there is also the spectrum of acute kidney injury patients, like the myoglobinuric AKI occurring in the crush syndrome in the times of earthquakes, COVID-related AKI, and leptospirosis AKI during floods are also examples of AKI in such disasters. We should also be familiar with this term, kidney failure disaster. Is a dialysis requiring kidney failure patients placed at risk due to lack of transportation, leaving them immobile and unable to receive treatment in time, and contamination of water systems, forcing the dialysis centers to close. The most common natural disasters are the climatological disasters like floods, followed by meteorological disorders like cyclones and hurricanes. And there are also rarely hydrological disorders like tsunamis and geological disorders like earthquakes, fire, heat waves, and volcanic eruptions. And biological disasters like epidemics and pandemics. And man-made disasters like wars, terrorist attacks, explosions, and radioactive contaminations are also not that uncommon. And there are hybrid disasters which caused both by human errors and by environmental factors. And whether the COVID pandemic was a hybrid disaster, its controversy is still day man-made disaster of Ukraine war, and what is happening for our dialysis patients there. There's an article published in CJASN on the dangers faced by Ukrainian dialysis patients, and it shows that many of the dialysis patients in Ukraine had migrated to the neighboring European countries, and some of these patients but remained back in their homeland, and numerous dialysis centers are deployed in areas that are less frequently under attack to provide the hemodialysis services, and courageous nephrologists and staff remained in the clinics, sometimes moving dialysis equipment into basements to continue treating their patients. And it's shocking and disheartening when we read this sentence that the devastating bombardment of Mariupol deprived patients on hemodialysis from accessing the dialysis clinics. And one patient who successfully evacuated after Mariupol bombardment reported that 49 out of the 50 patients at his center had died. The large-scale natural disasters disrupting the infrastructure could jeopardize the transportation, the electrical supply, water supply, and the communication systems. And these serious societal disruptions could result in dialysis interruptions, which could culminate into life-threatening events for the dialysis patients. They're also facing other challenges like overwhelmed health services, food supply chain being affected, and inadequate supply of disposables and dialysis materials, and staff shortage. Very few studies have addressed the effects of disasters. And of the direct effects, only one study has reported enhanced mortality among the dialysis patients during a natural disaster, but all the studies have reported enhanced emergency department visits and number of hospitalizations in the first week after the disaster. One study also reported on the mental health effects. Even under normal circumstances, for many of our patients, dialysis is stressful. So to undergo dialysis in a chaotic disaster environment means more added stress to them. Also, they will be lamenting or mentally nurturing a lot of losses, like they will have to face the financial losses or loss of property, death of loved ones, absence of friends or dear ones near them, and even leaving the pets behind. A lot of mental problems they'll be nurturing, and they'll be confused whether they are going to receive the next treatment. They don't know whom to contact. Hence, all this could lead to depression and post-traumatic stress disorder for the dialysis patients. understanding the fact that the renal care patients need urgent care in the aftermath of disasters, ISN, as early as 1989, established the Renal Disaster Relief Task Force. And its primary goal was to assess the dialysis treatment in a disaster environment and to infuse necessary manpower and materials in rapid succession. Its initial response was in 1999, Turkey earthquake. Just now, recently only, Turkey has to undergo the effects of a massive earthquake. And in 2005, Kashmir earthquake, the RDRTF again brought a lot of relief measures. And in KI, there's an excellent write-up by the then ISN president and KI editor, Professor Norbert Lammeyer. And in that, he has there is mention of deploying Belgian air forces to bring this dialysis equipments to the earthquakes struck areas of Kashmir. But the RDRTF mainly aimed at giving dialysis assistance to those patients who developed AKI during a natural disaster. But there was no mention of attending to the needs of maintenance dialysis patients at that time. And this is a study which was published after the Hurricane Katrina, and this was the first study pointing towards the factors leading to missed dialysis sessions and hospitalizations in hemodialysis patients. They had done telephonic interview of 389 patients from 9 hemodialysis units in New Orleans, and they found that about 44% missed at least one dialysis session and 17% reported missing 3 or more dialysis sessions. And the likelihood of missing dialysis was more for those with dialysis vintage less than 2 years, those who were living alone or placed in shelter units, and also those who did not know about the dialysis facilities emergency plans. And the Hurricane Katrina was soon followed by other destructive hurricanes like Hurricane Rita and Wilma. And a key lesson was learned that the kidney community was not prepared to face these disasters. And the catastrophic 2005 hurricane season alerted Americans to the need of a more effective response to mass casualty incidents. And to address the needs of the nephrology community, a committee called KCERC, that is a Kidney Community Emergency Response Coalition, was formed with representatives from more than 50 governmental agencies and private organizations, which included many hospitals, dialysis facilities, NIH, FDA, many dialysis equipment companies, and state governments. And since then, KCERC takes a leadership role in combating the natural disasters, and it will raise the relevant issues. It will identify resources to ensure continuity of care for kidney patients, and it also will help in planning. But this planning may not work for all facilities under all circumstances. And this is a timeline of emergency preparations which KCERC has recommended. The top column is for the dialysis facilities and dialysis patients, and the bottom row is for the emergency providers and the KCERC and the ESRD networks. And the KCERC does conference call every day, and this timeline starts 4 to 5 days before the disaster, continuing to the disaster and post-disaster too. So how can we translate these KCERC recommendations to develop our own disaster plans? For the pre-disaster preparedness, the recommendations for the dialysis facilities could keep as each individual facility should develop its own disaster plan. And this plan should be started by doing a local and regional environmental scan to identify what type of disaster or damage the facility is likely to sustain. For example, for a dialysis facility in Idukki district, which is more prone for landslides, its facility disaster plan might be different from the disaster plan of another dialysis unit located either in Aluva or Alappuzha, which is flood prone. And if in a flood-prone area is dialysis unit, they should look at like whether they have kept the dialysis materials high off the floor to maintain its sterility. Like there's an example of the way the plans are made. And also all the facilities should have an emergency evacuation plan at the time of a disaster. If in case an emergency evacuation needs to happen, and rehearse this plan on regular basis. Before NABH and JC inspection, we do conduct fire drills in our hospitals and in our units. Just like that, we need to conduct emergency evacuation drills. And the patients should also be taught about this techniques used, like the 4-clamp cut technique, etc. A video demonstration of this should be shown to the patients, and they should also be advised not to panic if in case an emergency evacuation occurs. And all the staff should be trained to conduct patient teaching. The patients should be taught about the dry weight, etc. And also we should have efficient communication systems, because it is very crucial for sending and receiving information at the time of a disaster. The mobile phones may not work at all. Landline phones sometimes might work. So it is best to have other alternatives. And one of the alternatives suggested is bidirectional satellite service, which is usually deployed by the military personnel and the border patrols. But this could be made available in the dialysis facilities, in the shelter units, etc. And there is also mention of an alternative communication system, that is ham radio. Ham radio, there are licensed ham radio operators in our state as well. This is from the press. Like in a recent landslide in Idiki, on an overnight, a ham radio station was established in Ernakulam, and there are a good number of ham radio members on spot for assistance during rescue operations. And another integrating approach for communication between the dialysis staff and the patients is installing GPS devices in the cell phones, so that the movements of the dialysis patients could be traced. And it's also necessary to build relationship with the local disaster planners and communicate with the state emergency management organizations. We should also plan for protection of patient medical records, which is very crucial. Like almost all the recordings is now in electronic medical records, but still it is important to have an offset copies. And this medical document should contain the recently updated medical prescription, the dialysis prescription, the serology status, the latest lab reports, and the contact numbers of all the dialysis staff, etc. And this should be kept in waterproof, easily accessible location. So the time of an evacuation, this can be easily taken. And every dialysis facility should form an affiliation agreement with another dialysis unit. Both with local and regional partners have to be found out and signed an affiliation agreement with this. For example, if I work at Pala, which is flood prone, I should have an agreement with a neighboring unit a few kilometers away, like maybe at Kottayam. I can tie up with Caritas Hospital, and so that contingency of dialysis care for my patients will be done. But if in case Kottayam is also affected by flood, then I can refer my patients to another facility in the neighboring district. For example, I could get into an affiliation agreement with Pushpagiri in the neighboring district of Pathanamthitta. And all dialysis facilities should have backup generators and adequate supply of fuel for meeting 2 to 3 weeks needs. And they should have extra storage of potable water. Also, the dialysis facility manager should communicate with emergency responders frequently, and including the CKD networks. And there should be a website, and notification should be given in information database whether the unit will be functioning or not. And this notification should also carry the list of all the patients in the unit. Also, it is important to train emergency volunteers at this time. There's something called PrepD, that is preparing emergency personnel in dialysis. This is a just-in-time training for the voluntary healthcare personnel on the basic steps of dialysis, so that they can support the dialysis staff. And for patients also, we have to prepare them We should give them adequate education and advanced warning. Also, we should give an early prophylactic dialysis so that even if a dialysis missed, its effects are mitigated. And they should be planned for an early evacuation. They should be guided to find out the shelter site. Like they can have personal preferences like hotels or their friends or relatives' home, or they can be sent to special community evacuation centers like special shelter needs, etc. And there should be also proper contingency plans for transportation of these patients. And it's also important that dialysis patients are given an identification badge. For example, in Texas, they have given the officially color purple to the kidney community. So the dialysis patients, even in the emblem of the car screen, car windows, and their wallets, all will be colored purple so that they can be easily identified by the emergency personnel. And this patient should carry the medical documents, prescriptions, and medications, and they should be aware about the 3-day emergency renal diet plan. This is a diet which is aimed at low protein, low salt, low potassium, high carbohydrate, and low fluid intake diet. And this is the example of the first day diet in a 3-day emergency diet, but this is not, this cannot be applied for our population. We have to chart out with the help of our dietitian colleagues, a diet which can cater to the taste of our dialysis patients, as well as depending upon the availability, local availability. So this is a thing which we have to formulate, the 3-day emergency diet. And the patient should have less than 500 ml of fluid per day, and very low potassium and low sodium diet. Also, special consideration should be given for patients who report post-discharge from central vein catheters. This is possible, like if water immersion has occurred during a flood, and they should be given isolation during the dialysis. Also, in a rare instance, if hepatitis B seropositivity is not known, we should take all precautions to dialyze such patients with the infection control precautions designed for hepatitis B seropositivity patients, like the dialysis should be discarded and the machine should be cleansed with the bleach. The emergency responders also have to be educated that dialysis is life-sustaining, and the medical personnel in the shelters should assess the dialysis patient shortly after the arrival to the shelter units, and they should be asked for symptoms like shortness of breath and muscle weakness, and determine whether an urgent dialysis is required for these patients. And if a lab facility is available, it's good to check serum potassium or even do an ECG. And during disaster, all the functioning dialysis centers should be open for extended hours and should offer more treatment sessions. And upload the site information that the site is functioning in the website. Address patients' special needs, especially look at the mental health as well. And triage for patients requiring urgent care is also required. And the staffs of 2 units, if the one unit is closed, that staff can go to the other unit and work close together. Alternative staffs like volunteer staffs could be posted. And for example, in KCRC, they have listed nephrology personnel who have volunteered to work like independent federal employees, and which include doctors, nephrology, nurses, and technicians. Post-disaster also, a thorough damage assessment of the facility should be done. Damaged supplies and equipment should be removed and replaced. Notify staffs and patients that facility is restored, and screening staffs and patients for post-traumatic stress disorder is very important. And we have to re-establish the normal routines as early as possible. And there is a publication available for the dialysis patients, helping in the emergency preparedness, prepared by National Kidney Federation. And in this, there is mention of the how patients should carry about the emergency go bags and what all materials has to be included in the emergency go bags. There is also a list on emergency and evacuation checklist, and there is a form for to be filled by both the patient and the dialysis care providers, which gives the information about their health, and as well as the transportation phone numbers and the dialysis staff phone numbers. And there are not much studies available on peritoneal dialysis and natural disasters. But there's mention that in hurricane prone areas, it is better to switch over to PD program. and there should be an adequate supply of peritoneal fluid. And those depending on automated machines should be trained to do manual exchanges. And there is only one study in PD which showed that there were 2 episodes of peritonitis in 22 patients. That one occurred because the person who is used to do automated PD, when he did the manual exchanges, he developed peritonitis. And other episode was due to application of river water. Because of the non-availability of the water, the river water was applied to the exit site. And there's a publication in ISPD journal by Raja Ramendran from PGI Chandigarh. They have reported 2 interesting cases of peritoneal dialysis during a flooding event in the region. And this events are that one patient with PD who was doing exchanges in the night was awake at the time of a flood so that he could save his family when the neighboring community was totally perished. And another interesting event was that a soldier who developed acute gastroenteritis and AKI, he was taken for an acute peritoneal dialysis by a surgeon who put a Foley's catheter into the peritoneal cavity and did peritoneal dialysis, and thus his life was saved. And until now, I was talking about saving the lives of our patients. But what about us and our nephrology colleagues in dialysis? Like there is a review in CJASN on the spectrum of burnout occurring in nephrology personnel from earthquakes and hurricanes to COVID-19 pandemic. Burnout is a psychological response to work overload, which is a frequent occurrence even during routine nephrology practice. But this is becoming much common during mass disasters due to increased workload, specific conditions, and individual factors. Even personally, we might be affected by the disasters. We should make our own self-preparedness plans, and as well as a family preparedness plan should be made by us. And this burnout of nephrology personnel could enhance the psychological somatic health problems, malpractices, understaffing, and inadequate healthcare delivery, which could already a compromised health care of the disaster is again compromised by this inadequate healthcare delivery during burnout of the nephrology personnel. So it is very crucial to take preventive measures for this. We should increase the safety. We should optimize medical staffing and material supplies, motivate the personnel, take care of the physical as well as the mental health. Also, enable flexibility in the working circumstances. A brief mention of the COVID-19 guidelines. Nephrology Association of Kerala was the first state chapter to come out with COVID-19 guidelines at the outbreak of the COVID in March 2020. And under the guidance of senior members like Kashi sir, Uni sir, and Sridhar ma'am, the executive committee could form very effective guidelines. And these guidelines help to screen the patients for a presence of COVID even before they reach the hospital and at the entry. And also instructions were given in the waiting room as well as inside the dialysis for effective preventive measures. And we had given pamphlets in Malayalam language for preventing this COVID transmission for our patients. And we were the first to come out with a COVID-19 risk assessment form, which was filled by the assigned staff for every dialysis patient. And with this effective screening and preventive measures, we could reduce the outbreaks of COVID-19 in our dialysis units. And we had also come out with recommendations for the protection of healthcare workers, as well as an effective delivery of the dialysis service by them. And there was also recommendations for treating, giving dialysis to the patients when they become COVID positive. And at the only one point I would like to remember at this juncture is that at the end, we are coming towards the end of COVID pandemic probably. Like it has become an endemic now. But there was an attempt by NAC Executive Committee, President George Kurian sir and President Usha ma'am, Secretary George Kurian sir and Sridhar ma'am to form a Google format. Questionnaire was put in the WhatsApp group of NAC, and like eliciting responses for assessing the data of dialysis patients and COVID, and also as well as the transplant recipients and COVID. But the response was quite poor, so the data assessment could not be completed, and it's the work is still remaining incomplete. So whatever I was trying to communicate to you in the last few minutes is that mass disasters are on the rise and will continue to occur. Any major disaster has the potential to place renal patients in jeopardy. Unpredicted disaster could be a renal disaster too, but with the present technology in weather forecasting, we could predict many of the disasters, so we can plan ahead, rehearse, critique, and reuse the plan. Each dialysis facility should have its own disaster plan, and this plan should address 4 phases of emergency management: prevention, preparation, response, and recovery. And it's time Kerala state needs to innovate policies and tools to meet the challenges the region faces from natural disasters. And I hope Nephrology Association of Kerala, now empowered by the new Win Kerala chapter, who has at its top the organization very giants in nephrology like Vimla Madam and Srilata Madam, to join hands with the state government to formulate policies and measures to protect the lives of our dialysis patients during a natural disaster. So we have to go a long way before we keep our patients safe. Thank you for the patient listening, and especially a vote of humble gratitude to Srilata Madam and Manju Thambi in giving me this opportunity to share whatever little knowledge I have on this aspect of disaster nephrology. Thank you.
Thank you, ma'am. Thank you for that wonderful talk. Thank you for shedding light on the practical aspects that we have to take care in the event of an unforeseen disaster. You have done full justice to your talk and have covered every aspect of the topic really well. So now the session is open for discussion. I hand over the session to the chairpersons.
Thank you, ma'am. Thank you, Manjula ma'am, for that excellent presentation. In spite of your health issues, hope you get well soon, ma'am. She has given us many points where we can improve our preparedness, and not only for the patient benefit, but also for the benefit of ourselves, that is to prevent burnout of the nephrologist and other healthcare workers. She has introduced us to the KCRC recommendations, which we have to modify. Thank you, madam. Over to you, Dr. Shrija.
Yes, ma'am. It was really a very elaborate talk, and you covered almost all the topic, all the natural disasters that we have ever heard of, actually. So it was such an elaborate session. So the topic is now open for discussion. So is there any query? I didn't notice any query on the chat box. Is there anything? So if there are no questions on the topic,
Jyotipriya, you're muted.
Yeah, I'm not able to see any questions. I think it's all very clear for all the participants.
So
if any of the panelists or participant has any query, you can type in the Q&A box. Yeah, I think we are not having any more questions.
Okay, so
Okay.
Thank you, Jyotipriya, for the for this session opportunity to chair the session. Okay, so over to you.
Thank you. Thank you, ma'am, for that wonderful, well-covered topic. And thank you, chairpersons. Now we'll move on to the last session of the day, vote of thanks by Dr. Manju Thambi. She's the secretary of Win Kerala chapter and the senior consultant nephrologist, NIMS Medicity, Trivandrum. Over to you, ma'am.
Good evening, dear friends. It's now time to say thank you. First, I'd like to thank the Win India team who actually parented this whole session. It was their brainchild. So thank you, Dr. Manjusha and her tech team, Siddharth and Rajkumar. I think Rajkumar is still there amongst the panelists now. Thank you so much for all the tech support. Also to Dr.
Thank you,
Urmila
ma'am.
Anand.
Yeah.
Yes, Rajkumar, thank you so much.
Welcome.
And Dr. Urmila Anand also, who's the president of Win India, for giving us this idea and for hosting this venture on a big platform. On behalf of the Fraternity of Lady Nephrologists of Kerala, I would like to extend my sincere thanks and regards to Dr. Joanne Bargman, who took her time out of a busy schedule, that too on a Sunday morning for her. And that was a wonderful lecture. And I've got so many messages saying it was such a nice lecture, thought-provoking and with a whole lot of insights. And we are indeed honored to have her with us and hope we'll be able to hear many more of her lectures in the future. I would also like to express my deep sense of appreciation to Dr. Manjula Ramachandran, because this is not a very easy topic at all. You know, you walked us through the lessons that we learned, especially during our floods, disastrous floods, and also during the COVID pandemic that we had in the state. Thanks to Dr. Deepa for that excellent case presentation and loads of appreciation to her mentor, Gomati Madam. Thanks also to the chairpersons of the sessions, Dr. Ragi Krishnan and Dr. Devi Sruti, Dr. Sripa PG and Dr. Manju Kamal, Dr. Srija S. Nair and Dr. Varada Arvindan, and also a glamorous host, Dr. Jyoti Priya. I also humbly thank the leading lights of our Win Kerala chapter, Vimala Madam and Srilata Madam, for all the love and support. And before we wrap this session up, let's take a moment to truly reflect on the work that we do, hoping to change the world for the better. Quoting the great Albert Einstein, only a life lived for others is a life worthwhile. Wishing every continued success in their journey as doctors and more importantly as human beings. Thank you and good night.
Thank you. It's been a very exciting and highly informative Sunday evening. As I told you initially, Win Kerala is having an incredible journey, and undoubtedly today's whole session is another feather in its cap. We'll be definitely continuing this amazing journey, and in future also we'll be having similar enriching, vibrant, didactic academic sessions like what we had today. So let's work together and take Win Kerala to new heights. Thank you one and all. Thank you especially for being with us till this final part. Thank you and have a great World Kidney Day celebration. Good night.
Yeah, that was a wonderful day today. Thank you.
Thank you, ma'am.
Good night, everyone. See you after 2 months.
Yeah. Good night.
Good night.
Good night.